Hello everybody and welcome to Facebook Friday. This is Kate Wakelin. I'm the Net Patient Support Nurse with NeuroEndocrine Cancer Australia, and each week we join you live to address a topic of the week and I guess provide some insights about NETs and navigating that experience of living with NETs ongoing. So before I go any further, I just want to acknowledge the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation, and just would like to pay this opportunity, pay my respects to elders past, present and emerging. One of the things I know that most of the community know about me is that I love to go for a run along the Yarra River, which in the Woiwurrung language is called the Birrarung. And so, yeah, look, I'm very grateful for where I am lucky enough to live, but also knowing that people are joining us from all of the various corners of the country, and so extending that acknowledgement out to everybody else as well. Now, you'll notice that I've got a guest with me, so I'm not going to spend much time at all talking about anything else to start with, and I'd like to introduce Dr. John Laden. Now, John is really familiar. I know that he doesn't need a lot of introduction for many of you because he's a very well-known name. John is a cardiac anaesthesiologist, which is why we've got him along today to pick his brains about Carcinoid Crisis, but John is also the co-founder of NeuroEndocrine Cancer, formerly the Unicorn Foundation. And so I've had the privilege of working alongside John as one of the board members and previous chair of the board of NeuroEndocrine Cancer Australia, and it's been really wonderful to be able to do that. I just, full disclosure also, that this is my last day in the office in my role, and I've got the tissues, I've just been howling all morning, but I've put a little bit of lippy on, so I'm just going to try and get through this and be dignified. We'll see how that plan unfolds depending on how everything goes. But first, we're going to concentrate on Carcinoid Crisis. Now, John and I agreed to this date months ago. We said, like, on the 2nd of July, it's the 2nd of July, by the way, everybody. On the 2nd of July, we're going to get John back. He came a few months ago and talked about COVID vaccines and risk of carcinoid crisis in the context of vaccination. It was a really great conversation. I'll make sure I put a link to that in the notes. But today we're going to just focus on carcinoid crisis because this is something that is a very real issue for people with neuroendocrine cancers. And I know it's a cause of quite a lot of anxiety for people because they worry about whether they're at risk of it and under what circumstances and what on earth they would do if that happened. And I also just want to give a shout out to one of our group members. I'm not going to mention any names, but I know that actually someone in our nearest and dearest in our Facebook private discussion group has had some treatment this week and actually had a carcinoid crisis. And I swear I didn't plant anything for that to be a setup for today's broadcast, but I know that she's been in hospital this week. And this particular lady is from the country and away from family and friends and stuck in hospital in Melbourne. And so just, you know who you are, a big shout out to you, and I know that you have been living this as your reality for the past few days, so it's a really good opportunity for us to unpack that all a little bit more. So John, in the context of being a cardiac anaesthesiologist, I suspect you already probably knew heaps about carcinoid crisis, but then having a family member, actually more than one family member with various forms of NETs, this has become an area of increased focus, and I know that you are considered to be an expert in managing carcinoid crisis from an anaesthetics point of view, not only nationally but internationally. So we're very grateful to you for joining us, and we're very lucky, very, very lucky to have you in our midst. So thank you. And I've got some questions, but I'm sure our community have some as well. So I'm going to be trying to keep an eye on the comments, which hooray I can see, and hooray the sound seems to be working, which is just like the last day of work present for me, because last week we had a few problems. So John, welcome. I'm going to stop talking. What did I forget to say about you?
Nothing at all, but thank you so much, Kate. And obviously, you know, I have known you for a long time. You have been a significant and unbelievable.
We'll do that afterwards.
Okay, thank you.
After we're
okay.
caught with, you know.
So, okay, carcinoid crisis. I would encourage you all to please send your comments to Kate. I have been involved with anaesthesia for 25 years now, including my training.
Fun fact, I was actually in my grad year at the Alfred Hospital in the very early 90s as a baby nurse, and John was working on the same ward, I believe as a registrar or a fellow or something.
I was senior resident or something like that.
Probably like that. Down in the gastro.
Was it 6E or
4E at the Alfred Hospital. Yeah. Oh, the memories of those days. Anyway, sorry, we're digressing. This might be the tone of the day, but anyway, let's
first of all, today I just want to give people a little bit of confidence. It is a very nebulous area. When I say that, murky area, carcinoid crisis, because there is a lot of fear for patients about it. There's a lot of unpredictability, and I get calls now probably nearly once every 10 days to 2 weeks from someone, particularly at North Shore or something, asking me for advice about how to handle the patient with NETs coming to surgery. Needless to say, all of you will be a frequent flyer when it comes to some sort of surgical procedure or sedation or anaesthesia. So I think mentally you've got to prepare yourself that this journey is a long one, and please God it is, but it will be peppered with lots of interventions, investigations, and that's just a part and parcel of where we're at. You must also realise that you can be managed and handled safely in the appropriate circumstances. Now, that could be at Orange, that could be at Peter Mac, or that could be at Royal Brisbane. With the main thing I would encourage you all to do is ask the right questions and be prepared well and truly beforehand. Now, when I say that, we're not talking about the emergency surgeries or the emergency interventions. That is a different story again, but when you are planning for surgery or anything, you yourself have to mentally and emotionally and physically be ready for it. And that means a bit of advocacy on your behalf, ensuring that your surgeon has a good anaesthetist or whatever, and they're aware of everything. So, and this is something that Kate and Simone and all the NET community have talked about, ensuring that you've got a good team around you going forward. Anyway, carcinoid crisis. What is it? When does it happen? How does it happen? Why does it happen?
Yeah, let's start about, what's the difference between, we hear about carcinoid syndrome, we hear about carcinoid tumours, and then we hear about carcinoid crisis, and for a layperson, especially someone who's a newcomer to this whole weird world of different language, what's the difference, particularly between carcinoid syndrome and carcinoid crisis? And I'll just say there's other videos that we've done on carcinoid syndrome, so I'll make sure there's a link to that in the notes. I don't want to go into that in too much detail, but it's important that we talk about, well, what's the difference? Is it just, yeah.
Okay, so carcinoid syndrome by definition is a constellation of symptoms and signs that we recognise was produced by the excess production of serotonins and carcinoid, let's say, call them related hormones, because there's a myriad of them.
So it's not just serotonin, is it, John? It's more than one hormone.
More so let's call them hormones. We don't, the specifics aren't that important currently, but they all act concurrently to give you that flushing, the asthma symptoms, the diarrhea and bowel, and urgency of bowel action. Over time, some of these hormones can affect the heart, and we get carcinoid heart. But it was really a syndrome of bronchospasm or asthma-like symptoms, flushing, and bowel habit, change of bowel habit, diarrhea. So that's the syndrome. Now, we know over the last 100 years, or since it was first described, or carcinoid was described, other symptoms as well. There are mood changes, lethargy, fatigue, skin changes, all those. But that was the three main sort of symptoms. So that's what some of you have experienced prior to being truly diagnosed. on the spectrum, a carcinoid crisis is related to those same hormones that the tumour can release, but in far greater excess, and therefore it will cause a different or a greater magnitude of those symptoms. So greater flushing, you still get the flushing, the diarrhea, the bronchospasm or asthma-like symptoms, but you also can get what we call hemodynamic or blood pressure changes. And the ones that of concern are very, very low blood pressure, or it could be very high blood pressure. And the other one is your heart rate can go all over the place and therefore can lead to collapse. Now, so that in a nutshell is what happens. Most of our patients, or the likelihood of a crisis for anything is really, depending on the literature, between 1 in 25 to 1 in, to 1 in 3. 30% of patients come to surgery or having something done. So depending on the literature, and it's so unpredictable. And this is the thing that I've learned over the last 15 odd years, is we still haven't been able to truly stratify or work out risk profiles for patients. So given you've got a jet net or a pancreatic net or a lung net, we can't actually say, based on this, you have a certain risk profile to have a crisis. Some of the sickest patients can go through a big liver surgery, big pancreatic surgery without a hiccup. Whereas others with small tumour burden, with very small tumours in the gut that we're monitoring or anything like that, can sometimes have a very rocky road. And that leads me to the most important thing, which I was alluding to, is just good preparation. Prepare for the worst, hope for the best.
So I wondered, there's some good questions coming through in the chat. So thank you, everybody. Someone just said, that she never wants to go to the dentist again because she's feeling so anxious about having another carcinoid crisis. There's two questions, and the one is from the feed, so I'll ask you that one, but I also want you to tell me the second question. So I'm going to tell you both at once and you can go for it. So the first question is, why during my carcinoid crisis could I hear and talk but not see? I always wondered. So that's the first question, which I'm like, I don't know the answer to that either. I'm glad you didn't ask me that, because I would have been ringing John. The second question is, so you were talking about it's difficult to predict. Does that mean that if you get really, terrible carcinoid syndrome day to day, does that mean that doesn't mean that you're necessarily at high risk of having a crisis during surgery, or is there a correlation there? So the questions are, why could I not see during my carcinoid crisis? Someone else said I could see and hear but not speak. That's really okay, but interesting. And then does your carcinoid syndrome prevalence predict risk in things like surgery, I guess?
Okay. What I look at when I'm advising, first of all, the visual loss, the hearing changes during a crisis could be related to either hypoperfusion, that is low blood pressure through the retinal vessels, and also one would say, or high blood pressure, low blood pressure, the same affects the ears as well. When you're anxious, you can hear blood rushing through your carotids, through near your ears, and changes in your hearing there. The vision, again, when we look at strokes, and I'm not saying you were having a stroke, amaurosis fugax was kind of a blackness or a veil that came over the eyes when people had a small blockage that cleared in their eyes. So I'm thinking that's more a perfusion, that is a temporary, transient, low blood pressure perfusion or whatever of the retinal or the eye vessels. I'm not being silly here, but there is also hysterical blindness in high anxiety states, and that one med student when I went to med school with, she would get hysterical blindness during exams or prior to exams, where she would just not be able to see.
Survival advantage you're a medical student.
So I don't know. Look, it's hard to know, but look, it's a very uncommon sort of symptom, but I could imagine it is related to the perfusion of the eye during the in that setting.
And the inability to speak. Like, I mean, people lose consciousness with carcinoid crisis, can't they? So I guess this is kind of part of the cascade of losing consciousness, is not being able to see or not being able to speak, and having some awareness, but still not being able to really do all of the things that your brain normally is able to do.
Exactly. And you know, transient weaknesses in limbs and all that. As I said, I mentioned stroke, but these are all things related to perfusion, blood perfusion of important neurological structures in the brain, spinal cord, but they recover when things settle down. You're not getting a clot, it's just related to oxygen supply to those specific areas. And if they're very sensitive, you obviously have change in the function.
So these are temporary changes that will resolve once we manage the carcinoid crisis.
Carcinoid crisis does not is not a precursor to stroke or neurological damage.
Great to clear that up. I could see the cogs turning in people going,
well, am I going to have a stroke? No. It's just related, you know, when you've got an army sergeant standing for 5 hours on parade, he suddenly loses vision and his heart rate slows and he collapses. That's a vasovagal, and it's all related to suddenly low perfusion to his brain, and he just drops. It's a safety, you know, sort of. So he's not having a stroke. You know, it's all blood flow related. You know.
Awesome, and I've got a thank you or two in the comments box. So I think that's cleared that up. That's really good to clarify, because I think when you're really going through, I've personally been through situations where I've been very ill, and you worry, am I going to die? Am I going to recover? And because your brain's not necessarily working quite so well, your thinking's not as clearly. Your thinking is not as clear either. So that anxiety can really run away with itself. And so if you're also panicking because you're thinking you really feel like you're dying, it's good to at least have all of this sort of information on board so that you know, oh, this is a carcinoid crisis. They need to manage this, but I will be okay.
Can I, one really good example, and I'll bring up the dental example that someone has posted in. The big thing with dental is, obviously, first of all, going to a dentist is anxiety provoking for anyone. Second thing is, local anaesthetic per se is not a bad thing for neuroendocrine cancers. What a lot of the time the dental practitioners use in their anaesthetic is a bit of adrenaline when they inject into very small doses into your lingular nerves or alveolar nerves to numb your jaw or your mouth for extractions or work. My thing is, local itself does not precipitate a crisis. The adrenaline, if inadvertently, even a micromil gets injected into a vessel accidentally, people suddenly, that amount of adrenaline hits the brain and gives you throbbing head, feeling of anxiety, palpitations. It's only a micromil. And I guess in the patient with neuroendocrine tumours, already at a heightened state due to their hormonal imbalances due to the tumour, yes, it's a very distressing and could be overwhelming experience. It may be the adrenaline rather than a true carcinoid crisis. So I always say, if you are going to the dentist, explain that you need to avoid adrenaline containing solutions, because you have a tumour that, you know, can cause high or low blood pressures if, you know, that was released. So dental work, you shouldn't be, I guess, afraid of dental work as long as you remove the adrenaline. It's very common. How often people say, I'm allergic to local anaesthetics. Why? Because in the dentist chair this happened. You go, wasn't the local anaesthetic, it was the adrenaline that they had in the local that was in, because it's such a vascular part of your anatomy, the mouth and everything. It's so easy. Happens all the time. As an example, I had a surgery on Tuesday night, and I had
Trooper John coming and doing a Facebook Live after surgery.
They numbed my whole arm by injecting lots of local around my nerves coming out the axilla. So my arm was dead. But I was hypertensive after surgery, and I was awake and all that. I was 170, 180 on 100, and I was going, oh, geez, that's a bit high. And of course, when I was speaking to the anaesthetist, he goes, oh, I think you've been absorbing a bit of the adrenaline. And the adrenaline keeps that local anaesthetic around the nerves and keeps it working for longer. But it did settle. So again, even someone who's relatively well, like myself, mentally not, maybe not, but it was being absorbed and my blood pressure was really high and I could feel my head throbbing a little bit. I went, oh, what's going on there? Am I anxious? What's going on? Maybe, you know, so that's an example. It can happen to all of us, even though that wasn't injected into the vessels, it was absorbed. So yeah, refrain from local anaesthetics with adrenaline.
So another question, have we talked about, oh, maybe we'll come back to is bad carcinoid syndrome a high risk for carcinoid crisis, but okay, and then I'll get to, there's another question, there's questions coming.
Okay, when you look at yourself, this is important, when you look at yourself coming to surgery, I have a few golden rules. Yes, you look at the frequency of your carcinoid symptoms. You then have to say, are they quite well controlled currently on my depot preparations and what I'm on? If they are,
depot meaning monthly butt jabs for the lingo of the support group.
Yeah, your monthly sandostatin, lanreotide, whatever. So yeah, the frequency, we used to always say those who are always got diarrhea, always flushing, maybe at a higher risk, but that doesn't always come to pass in surgery. I used to always say, oh, if they've always got, this is 10 years ago, I might have said, yeah, we'll be a bit more wary. You've got it in the back of your head, but it's not a direct correlation, okay? The main things are, you're coming to surgery, you're about to do anything, make sure the timing is good. What we try and do is make sure your timing is good. That is, you have surgery at, maybe a week after you've had your monthly injection. You obviously keep up with your regular medications. That's about it. You then also need to be explaining, your surgeon needs to have an anaesthetist who has the ability to manage carcinoid crisis, which most anaesthetists do. Once I speak to them, they get very confident. Oh, thank you. I now feel I can manage this much better with octreotide. So they need octreotide and they need monitoring.
So can we talk prevention, John? Because
it's hard though.
Yeah.
Prevention is, again, what are we preventing and why? Most of the time crises occur usually perioperatively or surgically when we are managing.
Perioperatively means around an operation.
Yeah. And there are triggers, as we said, that may release a crisis, high anxiety or adrenaline if you got that injected or something potentially. But de novo crises are not very common. High levels of symptoms are common, so you might have high level of flushing or diarrhea, but how often do we see a patient truly collapse with hypotension or hypertension? Not very commonly when they're on their day-to-day meds and doing what they're doing. It's usually if you are going for PRT or if you're going for liver ablation therapy or you're going for surgery. Or
if there's a person who, there's two scenarios. Oh, wow, okay. There's scenarios coming thick and fast, but the two ones that are in my mind are our person who's had a really quite extremely dramatic situation happen in the dentist chair, and we've talked a bit about that, but also our lady who's currently in hospital and she had PRRT and she had a full-blown carcinoid crisis as part of her PRRT experience. She had the enhanced version. For those sorts of people where, like, it might be that our gorgeous dental person needs to have some dental, and we all need to go to the dentist, but maybe she needs a filling or a tooth out, or this person who's had a carcinoid crisis with PRRT, is there something as an anaesthetist that you could suggest that they might do ahead of time, next time, to reduce the risk? Can we prevent it like that?
Yes. Well, we've just, it'll be published soon, hopefully, in NeuroEndocrine. I was involved in a protocol for North Shore for our PRT service, whereby, we went through the literature looking at the incidence and outcomes of around the time of PRT, carcinoid crisis. And it's a phenomenon, it's there. And what we have decided on is, we do get the patient in, those who are at higher risk or at risk, load them with octreotide, or 3 times doses in the first day or 2 before. So there are protocols, and Peter Mack will have one. We worked with them, but I guess the issue is, it's again, not how many hundreds of people we've seen go through PRT, how many have we seen have a crisis? Maybe 1 in 100, and unfortunately this poor person has experienced that. Now, obviously, you are getting PRT in a centre that can handle carcinoid crisis, and it's suddenly, in that setting, we can't predict that you've got it, but in that setting, we need to act quickly and recognise it early. Does that make so? There's 2 things.
Yep.
The issue is, unfortunately for all you beautiful people out there, is, I'm telling you, it is unpredictable. And unfortunately, it's something you just got to deal with. But in that, you need to say, if it is a bit unpredictable, I need to go somewhere that if it does happen, they can treat it.
And I would add to that, John, I think you're absolutely right, that actually, it's a question, it's a reasonable question to ask if you're being lined up for PRRT, and we know that there are more and more clinics offering PRRT. They've discovered it in the prostate cancer field, so there's other clinics popping up. But something that you can ask as a patient is, to the team delivering that PRRT, what do you do if I have a carcinoid crisis? Do you have a protocol?
Absolutely.
Is there an intensive care unit on site? Where is, so they're reasonable questions to be asking, because we know that not every service is going to be run the same way. It's a good question to ask because it'll help you be less anxious.
And it's very important to realise that, handled appropriately, it's a distressing experience for the patient, especially if they're awake. But it's handled properly, you'll get through it. It's just a matter of, early recognition, and that happens in good centres who do PRT or look after net patients. And Kate, you're totally right. Your corner store PRT provider who's charging you X amount of dollars may not have, I wouldn't go have PRT there when I have registrars and consultants who can say, grab the octreotide, let's give an injection of that. Because octreotide, which is still the mainstay of treatment, has a wide margin of safety. It's just that not many people are confident in using it. Now, that's why I try and instill in the anaesthetists and people treating nets, use it, okay? See what the response is, use it. And we're just trying to block those receptors, the somatostatin, what we call somatostatin receptors. And I guess that's the most important thing. So I really want you beautiful people to realise, ask the question, get them prepared. And if you get a terse response, we'll say, I'm sorry, I'm not happy with that, and go somewhere else. I think you've got, if they're going, oh, it never happens, I've never seen it. Well, you go, well, there's still a chance, isn't there? So let's prepare for it. And if it doesn't happen, I'm really happy too. That is my attitude to all this.
No one minds a dry umbrella, do they?
No, exactly. And that's what I say when an anaesthetist calls me, like a patient last week. She goes, oh, John, they were doing a liver ablation at North Shore, and she was concerned. I said, look, just have it ready. It's very hard to determine, but have it ready. And it all went swimmingly well. And that's what you want. No, no dramas. Yeah. And she said, it was so good to talk to you and get my head around what was going on. So, and I think
the other thing, just before I forget about PRRT, I hear a lot of people, I think as patients, we can be, and I've been a patient, not a cancer patient, thankfully, but I've been plenty of times a patient where I've been watching myself thinking, why aren't I speaking up? I feel awful, or this person's being mean, or I can see this person's not doing this procedure correctly on me. Why aren't I speaking up? And I think sometimes as patients, we become very meek and mild, and we don't like to rock the boat. We don't want to question things. It's like going to a restaurant and complaining about your food and worrying they're going to spit in your dinner or something. Like, I think we get worried about asking questions. Be really confident about that. But the other thing is, if you are not feeling well, whether it's a dental procedure, whether it's PRT, whether it's having your tummy examined. I heard a case down here in Melbourne of someone where a medical student was palpating the patient's abdomen, and they obviously had very, very hormonally active tumours, because that person went into a carcinoid crisis with an examination, which is like, that is very, very rare. But we've got to speak up as patients. You've got to speak up. If you're not feeling well, if you feel like you're going to throw up, if you anything, be the squeaky wheel, because then as your health professionals, we know where you stand. We can't read minds. So sometimes if the patient's sitting there quietly, we think, oh, well, everything's fine. But it might not be. You might just be a really good actor. So we're left guessing sometimes.
Very important. Again, talking about that palpating of an abdomen, the tumour must have been just under, and even the medical student's not delicate, having been one for a long time ago, poking and prodding, and the poor patient is lying there going,
putting up with it.
Yeah, and suddenly all they're doing is pushing into the tumour and releasing more of the hormone. So, again, to Kate's point, please speak up and clearly alert your doctor that I have neuroendocrine tumours and I am concerned about experiencing a carcinoid crisis. Do you have the supports there, if it occurs, and we're hoping it doesn't, to help me through it? And I think as simple as that will then clearly put it out. Even from a medico-legal point of view, you can turn around and say, I have clearly enunciated or said to them, I was concerned about this, even though it's a rare and an uncommon situation, I still want you to be prepared for it. And I think that's it. And then they go, all right, you then have to allow them to set that up. But you have to say it clearly that it is a concern, that we know it's unpredictable. I may not have it, but are you prepared? That's the key for all you guys listening. You want your team to have thought about it, prepared for it, even if it doesn't eventuate.
Exactly. And what we do have are some resources. So that's, you might be thinking to yourself watching this, well, how do I know? So there's some really one of the wonderful things about neuroendocrine cancer over the last few years is we've got this fantastic library of resources. So we've got a fact sheet on carcinoid crisis, which you can download from our website, and I will make sure the link's in there. The other thing that we have, and I'm kicking myself because you should see my bookshelves, which normally have all of the neuroendocrine cancer resources in them, and I think they've all gone. We have a little, they're all in the box waiting for the truck to come and take them all away. We've got cards. They look a bit like this, but this is one to use the toilet urgently, but I don't have the corresponding carcinoid crisis one. But there is a card that you can carry around in your wallet. It's plastic. It's really durable. It's like a loyalty card, and it's got the, alert, I'm at risk of carcinoid crisis. But importantly, it has both the dosage of octreotide that an emergency person would need to administer if that was happening, because I can never remember facts and numbers and things like that. So it's on the card. But the other thing is it's got the reference, it's got the journal article on it that, anaesthetists will look at the card and go, well, under whose law? And they can then look at the reference and go, oh, it's in the literature. This is a dicky die, a legit thing. I can trust this. And it's got the, they can look that up on their phone or whatever and verify it. But it means that you'll have that information on hand. So because this is my last day in the office, we can send them out free of charge, but there's just might be a bit of a delay for you in receiving those. But you can also download them from our website. So I'll make sure the link is in the notes to the card that you can just download and print, and then you've got it on your person. So forearm is forewarned, and I think information is one of the key things that we can do to help you manage your anxiety. I think most people feel much less anxious once they know about it, and once they've got the information for, you know, to hand over. Someone's just said you soon lose your confidence about speaking up, because you might get treated as if you're making it up and making their job harder. And this person said I could tell a lot of stories, and I'm like,
I know you can tell a lot of stories, and I'm 5 days a week clinical, both bariatric, both cardiac and other acute surgical procedures. But I swear I still say it's the way, if you just go, look, I am concerned. If your doctor gets the shits, well, then they shouldn't be the doctor. I'm sorry.
You should have had a holiday last year.
If your doctor goes, oh, you've been on Dr. Google, you go, no, I live with this disease and I am concerned about the potential of carcinoid crisis. And I can tell you, I give them my number. Say, Dr. John Laden, I'm a part of the College of Anaesthetics. I've been chairman of the New South Wales committee. I'm well regarded. Just pull them up and say, hang on, this is my body. I'm concerned. Are you prepared?
I know it's so much easier said than done. I really do know.
I do. But I guess
it's just so important, isn't it, John?
It is. You're not telling a person to suck eggs. You are saying, I am concerned, and you're not being hysterical. You're not doing anything. Are you prepared in the rare circumstance of if I had a carcinoid crisis?
Yeah. And
again, and if they and this is the information, octreotide is still the gold standard. You don't even need to go there, I guess. But again, you have to, if they say, thank you, yes, we are, you go, ah.
Yeah.
And if they have another response, you go, well, they may never have had treated a carcinoid crisis. You don't need to have treated one to be able to give the drug that will manage it. So it's very important, and it's so hard because I do get a lot of calls from anaesthetists saying, I've got a patient coming up, what should I do? And even recently I did advise, probably, and I spoke to the oncologist who's a very good friend, and I stood by my words. I had to advise one of our dear patients not to be anaesthetized in a certain hospital. And I said, if that was my sister or brother, I would want them in this hospital for this procedure, even though it's unlikely things are going to happen. But in that hospital, I know you don't have the supports if it did. And it created a bit of a ruckus here in North Sydney. But I stood by my words and I said, well, I know it annoyed a few people, and multiple anaesthetists were running around talking about things, and it was a prominent patient who's been supportive of the NeuroEndocrine Cancer Australia for years. But I still said, call me, and I'd still say I'd rather it in that hospital. Again, it's just one of those things. I think preparation and just trusting your team and knowing you've got the supports is key. Do not fret that every time you go do something, you'll have a carcinoid crisis. Please, that anxiety is counterproductive. The most important thing coming to anything is just clearly saying, I have a risk, a potential, it may not happen, but can you handle it? That will clear up for most of you. You'll go, okay, whatever happens, they can handle it. You will, people don't die of crisis if it's handled properly. And, even poorly handled crises, you get through. Most people will get through. And that's another important thing, in the short term. I'm not talking in massive big surgery, but in the short term, you will get through that as well.
So there's another question that's come through, and it came through ages ago, and the person who asked the question's been very patient because they might think I was forgetting it, but I haven't. The person is one of our unicorns, which is NEC. So for those who are newer to the neuroendocrine cancer scene, NEC is neuroendocrine carcinoma, and it's the really high grade. They're very, very, very rare, but it's the very high grade version of neuroendocrine cancers. So the question was, can someone with neuroendocrine carcinoma, so that's grade 3B for those watching at home, can they be at risk of carcinoid crisis?
Look, with NEC or neuroendocrine carcinoma, again, the cell type is more aggressive, and some of them are not so active hormonally. Again, it depends. Sometimes they're just growing unabated, whereas the 1 and 2, which are more indolent and maybe slow growing, are often more glandular and more often producers of serotonins and all those carcinoid type hormones.
So would it be safe to say that? Oh, sorry.
but again, with everything net or neck, there could be mixed disease as well. You know, so depending on the biopsy that you've received, did they just get those high grade cells, or was there some degree of mixing of low grade hormonally producing cells?
Yep.
And again, I guess it's based on your symptomatology. You know, if you have got carcinoid symptoms, well, you've got some of those hormonally active cells as well.
Yeah.
Okay.
Look,
but if you're asymptomatic, maybe you don't, you know what I mean? Or you don't have a bulk of them that would cause, you don't have enough of them to cause the symptoms, producing enough hormone, and therefore it may not be a problem. You know what I mean? You've got to overwhelm with carcinoid crisis, with carcinoid symptoms. There is so much hormone going around, you've overwhelmed your body's ability to break down that serotonin by the liver and other places, or the lung, and that's why you get the symptoms. So you've got a fair mass of those little cells. When I say it's not a football-sized mass, it's a mass of cells secreting endocrine, you know, those hormones. So overwhelming your own body's ability to break it down.
Yep. Yep. Okay. Hey, John, that has been super helpful, and I'm so grateful to you. I've got some other stuff to talk about. You might imagine.
All right, I'll be very quick. Let's see the questions you've got, and let's see if I can answer them all in 30 seconds.
They're gonna. I'm giving people a last minute wind up on the questions. There's lots of people thanking you and agreeing, so that's awesome. I think we have answered all of the questions that have come through, but just pull me up if you feel like I didn't. While we're waiting for everyone to scribble down their last questions, this is unusual. I did not plan to talk about this on my very last day at work, but it's important, and it's not to do with carcinoid crisis. So have a drink of water, John, but I did make some promises that I would cover it today because it's important. So one of the mainstays of treatment in neuroendocrine cancers are these monthly butt jabs that everyone really just adores, so whether it be sandostatin LAR or lanreotide. Now, what's happened in the space, in the pharmaceutical space and in the legal space over the last few months, is that there's been, even longer, the development of what we call a generic version of long-acting somatostatin analog. So it's the same kind of, works in the same way as lanreotide and sandostatin LAR, but it's like going to the pharmacy and getting Panamax rather than Panadol, or when you go to get your puffer, your asthma puffer, and it's not Ventolin, it's Ventex, or I don't even know what the other brand names are, but it's the generic version. Usually they are a little bit less money, but people would argue the variations, but the important thing for you all is that there is some choice in this. The thing that's important for you to know about, if you're offered a generic version of a long-acting somatostatin analog, it might be a different type of needle, like a different type of syringe from the one that you're used to. But the other really important thing is that both lanreotide and sandostatin LAR have a home injection support service. So they're different. Each service operates differently. They offer different things. But if you go onto the generic version of that drug, the company that provide that home injection support service are no longer able to provide that service to you. So for people who are having home injections with either of those drugs, if you take a generic version home and have it at home for a nurse or a doctor to come to your home under the eShine or the Ipsen Assist program to come and inject you, if it's not the product that they are contracted to give, they won't be able to give it to you. And so we're a bit worried, as an organisation, we're a bit worried that people might be sort of left short on the day, thinking that the nurse is going to come. It's in a slightly different box, but surely that's okay, yeah? It's not. So you need to have a conversation with the pharmacist and with your doctor. Have a think about it, like it's an informed decision, and for some people going to a generic might be a very reasonable decision that they would make. That's not my position to make a comment on that. But what I do want you to know is that if you do go onto a generic, if you are part of that home injection support program, you will no longer be able to access any of those services. You can still ring the net nurse, it won't be me, but you can still ring the net nurse and get support and information through NeuroEndocrine Cancer Australia. We don't mind what products you're on, but if that service is provided by a drug company, they're only going to give it to you. They're only going to provide it to you if you're on that particular drug, because their staff won't be trained to give the, you know, the other injection, you know, they can't have the same oversight over quality and all of that legal stuff. So John, you had a comment to make about that. I hope I'm not speaking out of turn. I just thought the legislation came in yesterday that this was going ahead, and we don't know when they'll arrive on the market, but it's going to happen, and I want to make sure everyone knows this. So, John.
Very, very important point there, and I think Kate's addressed it well with respect to generics and current branded product. I would be, I want to educate you all that.
I didn't warn you I was going to talk about this, John.
No,
sorry.
no. But knowing from personal experience with drug delivery systems, with anaesthesia and different producers, be them generic or the original brand, if your doctor is swapping you or saying you should try the generic, it is cheaper, and you're going from lanreotide or sandostatin or whatever, be mindful. If you feel there's any change or it doesn't cover you well, go back to your whatever was your original and best. You may have a different response to lanreotide, even though you're getting the same dose for dose equivalents or whatever, or the generic. You may get a skin reaction from the generic, or that you didn't get with lanreotide, or you might get it with lanreotide and not sandostatin. So our bodies are so different, and even though on the label it says this is a long-acting octreotide depot, the stuff they have in it, what I'm about to say to you might shock you, but if it ain't broke, don't fix it. If you're comfortable on whatever you're on and your symptoms are well controlled, you're not getting skin reactions, you're managed, I wouldn't go swapping anything personally. If you do swap things and you suddenly find after 2 or 3 cycles or months that things are a bit different, even though the dose is the same, I would revert back to what was working. Does that make, because
yeah, I reckon that's
I can tell you now, generic Panadol is different from something else. And I've had that experience personally in analgesics with surgeries. I'll have a Panadol for it, but it sent me off the tree. And the regular one was, I could tolerate, it treated my pain. So again, with drug formulation,
I hate the way that generic Panadol gets stuck in my throat. Does it anyway? It's my last day. I'm going off.
and it goes without saying, with all your natural therapies, there's a significant difference in different things are the same. If you're taking something that agrees with you and you believe you're getting benefit, I wouldn't change personally, because the production lines, be it India, Seoul, whatever, you just don't know so. I
know what you're saying, and I'm on board. I'm here.
So I'm just that's the thing with generic or other things. If you're on a good thing, stick with it.
So I've got some things I want to say, and Simone, I really, really, really hope the sound works. Talk.
Yeah, I hope so.
It's working. Hooray.
Hence, I'm on my phone this time. I didn't bother with the computer.
We had those of you who joined us last week will have seen our world of pain. It was pretty funny. Look, it's